because we don't want you to get a CAUTI. CAUTI is a catheter-associated infection, so we change your dressing under sterile technique. Do you have any questions? And of course, he wants to know what he has to do on his end. And I said, you don't have to do anything. I'm just gonna have to put a mask on you. And once, well, it looks like you already removed your dressing, but I'm gonna have you turn over there. And I cannot have you breathe on your side while I'm doing this, okay? Is that fine? Okay, good. We've already double checked. I got the right patient, right order and everything, okay? Provided privacy. We're ready to go. So we checked the site for any signs of infection. We've already flushed it. It is patent. That's good. And then we're gonna carry out our other procedures, okay? So what I'm basically doing, I'm just measuring from this port to the grave, okay? We're gonna use, it's inches, so we'll use insertion site and no infections. I noted that. And we're ready to go, okay? For your checkoff, make sure you're ready. So now that we're gonna start doing our dressing change, put the patient's bed up so that it's in, it's at waist level. Get comfortable. If you need to put your glasses, like mine are falling out, you just, get a band and get them close so it doesn't fall, because it's gonna be, you can't be doing this. You have to have your face and everything ready to go. So your hair is up, you don't have any of these little stringy hairs in your way, and you're ready to go, okay? So, I opened up my package here, okay? My gloves are clean, and we're just gonna set up, okay? There's different ways of setting up, you guys, and sterile gloves, and I could actually just fix that. I have my sterile gloves, I'm trying to be as meticulous. Okay, what am I gonna need? I could use this to lay it on the patient, whatever I wanna do, because this is another sterile field. So if something happens, I could even go like this and put everything right there, okay? As long as I'm sterile, okay? I'm okay, I'm past beyond that. I could work with what I have. You're gonna have your iodine. So I checked my allergies beforehand. He's not allergic to iodine. But most of the manufacturers now have chlorhexidine. But you still want to check for that if anybody's allergic to chlorhexidine. If they are, then you'll use the iodine. I'm not going to use it on the patient because I think it stains the mannequin, right? Yeah, so I'm just going to put it over like here. We're going to pretend, okay, that this is my chlorhexidine, okay? And I'm going to use it as my alcohol as well. So we're going to use your alcohol first, and then if it's, I'm just going to open it up and I'll put it as, sorry, as long as you're not squirting here, still pretty good. Alcohol, center first, we do a circle, turn it around, do another rainbow, turn it around, and then make another circle on the outside, okay? And we discard. Again, center, turn, and then on the outside. This one has a specific way of doing it, and then once we get the chlorhexidine, that one we can, that's okay. So we're gonna say this is my chlorhexidine. I just don't wanna open it. And that one you can scrub however you want, okay? So if this was my chlorhexidine here, since it's clear, this is my chlorhexidine, you're gonna get it and you're just going to scrub, 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 scrub. You can scrub anywhere and it's fine, okay? You're gonna scrub here with your chlorhexidine on the tubing. This one you can do anywhere, okay? It doesn't matter because it's gonna kill, it's a lot stronger than alcohol, okay? So you're gonna scrub that, and as soon as you're done, you're gonna let it dry. I know that you saw me drop, make sure it's not dropping below your waist, okay? So you can have your trash in here. I don't care about the trash, I know they're gonna get mad at me, but it's alcohol. We're gonna allow that to dry, and the next thing that we have to do now is put on our, we put our bio patch on, and then we put our stat lock, because if we do the stat lock, that requires me to open the skin prep, and it's gonna get sticky, and then my bio patch is gonna get sticky, so I usually do the bio patch, and then I'll do my stat lock. So, it's dry. No, it's still not dry, but it's okay. We'll wait, and then I'm gonna get my stat lock, okay? Open this up, and this is going what? Face up, and it's gonna go down like this, okay? So, we're just gonna lay it out like this. Okay? That's just gonna stay there, and then what we do have, if we need to maneuver the lines, we have this gauze that we're gonna use it to lift it up to put our stat lock in, okay? So, you wanna make sure that you're able to use whatever is in your package, so it's important if you use it. So we're gonna go ahead, get the skin prep, and I'm not gonna put it on there because it will stay on there, and the next person that is gonna have to check off will have a hard time taking that thing off because it will stick. So, but on a normal patient, the skin prep, you wanna put it on. Okay, so you'll open it up. You're gonna open it up. It's a clear little packet. And you're gonna put it, I'm gonna put the stat lock, and then where I'm gonna corner the Tegaderm, so it gets stiff. Let it dry. This part is the tricky one because you have a little butterfly. And so what I do first is once it's ready, I pull one side first. Well, you're gonna say, light it in there, clip one side, and then take one of the sides off, okay? So, what I'm gonna do is get my gauze. I'm gonna pull this up. And we're gonna stick it there. And this is the tricky part because it has like little. It's still slippery, but what we're gonna do is pull it on. This guy's here. And pull it down. Side, and we're just going to pull this part here. Sorry. And then I just stick it on the other side, okay? After that, can you lift up your arm, sir? He's gonna lift up his arm, okay? I tried. All you have to do now is now put on the Tegaderm, okay? Really, now I can't lift up his arm because I'm just gonna put this on, I'm gonna put this on. And the only thing sterile that I need is that center part. So, we're gonna go ahead and, I like to picture frame it, so I wanna see that most of that line is in that square, okay? So I'll put it on there. And lay it there, and I try to be as, I don't want a lot of wrinkles on my tape because that will cause, lay it down, yeah. And I will lay it down. And remove the Tegaderm. Remove the Tegaderm. And at this point, this is a clean part, okay? You don't have to worry about sterile anymore. The only thing you have to worry about is do not throw away the little sticky part for your date and time. So you throw that away. I'm gonna keep this little part just to guard my ports. There's a sticky part on the, is this okay, Mr. Smith?
Yes.
Okay, doing fine, okay? We're almost done, okay? Let me just, we're gonna just change our ports out. Probably the less invasive thing we have to do, and we're done. So what I'm gonna do, oh, yeah, sure. I almost forgot here. So I'm gonna get my 2 swabs. I'm gonna open 2 of these, 2 of my alcohols. And now we're just gonna change our ports, okay? We're gonna start with 1, it's locked, we turn it, okay? Once you're ready, grab your alcohol. This is where you have to be a little dexterous. So we remove it, and this is the one that we're gonna scrub. So you cover it up, and we are gonna do it for 15 seconds, a good scrub. 1, 2, 3, 4, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, okay? This is all good to go. I have my port ready to go. Okay, ready to go. Remember, it's sterile. Try to be as careful as you can not to contaminate it. And then we're gonna open it up, flush in this fashion, okay? Flush, 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 flush. It's not flushing. I don't know why it's not flushing. Okay, it's flushing out, but you wanna do this in a pulsating fashion. Once you're about midway, just bring it back. You should get some red, that's blood. That means it's good, because it's gonna ask you in the documentation to do that. So we push, 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 push. After that, and then as you're gonna get close to finishing your flush, you wanna push and lock at the same time so we can keep that negative pressure in, okay? And then we should make sure everything's nice and secure. If you are working in one of those fancy places and they have a nice cap, we can put a cap afterwards, okay? We're gonna do the same for this one. We're gonna lock it, twist it, get our other swab. Where did our other swab go? Right here. Cover it and then scrub for 15 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 15. Okay, and then what we're gonna do is open it and unlock it, splash it a little, pull in a pulsating fashion. Once we're about midway, pull back. We get blood, and then that pulsation helps break up any bourbon that gets collected in that line, okay? And then as soon as we're gonna be ready to flush, we wanna lock it and push at the same time. And then put a cap with orange caps. If they don't have the orange caps, you can get another 4x4. When you're done, I don't know if this is gonna be, you'll see the dialysis nurses, so you can cover it like this with a 4x4, a bigger one, and just fold it and tape it. You can do that, but we'll leave it at that for right now, okay? Last thing before I'm done, what is it? I'm gonna label it, because if I didn't document it, it didn't happen. And this is, Ramita's gonna bring her black pen, or your little Sharpie. Oh, Sharpie, thank you. And I'm gonna put the date. Today is the 12th, right? 25, and it is what time? 2:04, and I'm gonna put C. Ramirez, ABSN, or RN. And I'm going to go ahead and put this right here on the top so everybody can see where my date and time is and when they changed it. And I'm gonna go ahead and document that, okay? I'm gonna ask Mr. Smith, is there any discomfort? You wanna ask how they tolerated every procedure. He says, oh boy, I didn't even feel it. Okay, let's go ahead and take off that mask. I'm gonna put you back in a comfortable position. He's back in his bed. I'm gonna clean this area up. Don't forget to pick up your trash. And we can actually, at the hospital, they don't have, I'm used to the home health setting where they'll give you a little mesh that looks like a little fishnet that we can cover the site. If the patient needs to go to take a shower or anything, I tell my CNA, Daniela, I'm here, my CNA, okay? I just changed the line. If you need to do any bathing, just make sure you cover there's a plastic bag, or we just make a bag for them out of a little biohazard bag, and we take them, but it has to be covered when they shower. I let him know if he notices that there's any drainage, any pain, any redness, if the dressing is open or it's compromised, if there's a hole, he needs to let me know so we can change it, okay? If it's bloody, let's say it's not even been the 7 days, it's bloody, it's lifting, you know, infected, it's at risk for an infection, just go ahead and change it before the 7th day, okay? It can happen, patients sweat, and that is something that you may come across. But once I'm done, I gave him his bed is the lowest position, gave him his call light. I told him all the signs and symptoms that he needs to call me back. We have this covered as well. He's able to verbalize back 3 signs and symptoms. He needs to notify us and that he needs to have that covered at all times if he's going into the shower. He's aware, and I'll go ahead and document my procedure. Okay?
This is an example of a Medi-Port, okay? This is a standard Medi-Port. And what I mean with standard is that there's some companies that make them a little bit fancier. They're bulkier and they're like in a triangle shape, and that allows you to grip it better from the outside. Obviously, you're not gonna stick your hand inside the patient's chest, but it makes it easier for the nurse to maneuver. They also have 3 little dots on the rubber part. This front part is rubber. It's just like the vials from the medications. Once you remove the needle, it closes itself, so it's not leaking all the time. But the back part is pure metal, okay? So you cannot trespass the Medi-Port and go into the patient's rib cage or heart. So so that's the back part. Those 3 little dots that some of the Medi-Ports have is just a reference for you, knowing that wherever you see those 3 little dots, you go exactly in the center and you're gonna be okay. These are a little bit harder to maneuver because they're round, so you have to do a 3-point anchor, so you have to kind of like teach your fingers how to hold it, so it doesn't move. If you only do this, the Medi-Port, since it's round, it can be slippery and you're gonna miss the center and you're gonna have to be starting it every time. Since it's a sterile technique, every time you wanna start it, guess what? You have to do the whole sterile field and grab another Cuber needle and all that stuff. So it comes with the line. The line goes to the superior vena cava, and it connects to the heart through the right atrium. Sorry, the tip of it has to be on the right atrium. So it goes, the medications, whatever you're giving to the patient, it goes directly into the heart. Okay, so it is a sterile technique. When a patient has a Medi-Port, what could be some reasons for the patient to have a Medi-Port? Chemotherapy. What else? Just long-term medications, okay? Because this is a surgical procedure. It's inserted not at the bedside like a PICC line. A PICC line, you can insert it in specific areas, but not in. It's not usually done at a OR. And the Medi-Port has to be within sterile technique by a surgeon in the OR. So whenever you see the patient until you become a doctor, then you're just gonna access it and de-access, but the Medi-Port will be already in place. So what is it that you need to know before you start it is the purpose of the use of the Medi-Port. Not all the patients that get chemotherapy will have a Medi-Port. Some treatments are short term, let's say 1 to 3 months. So the doctors usually prefer a PICC line. The difference between one of the difference between using a PICC line and using a Medi-Port is that the PICC line has to be change the dressing every so often, every what? Every 7 days, versus a Medi-Port that has to be maintenance every 6 weeks, 4 to 6 weeks. So if the patient is going home, it's less of a hassle for the patient to come back every 6 weeks than to come back for a dressing change every week. That's one thing. Another thing is that if they're in the infusion area, you know that the space is very limited, staff is very limited. They don't want to be booking their schedule with a lot of dressing changes versus giving chemotherapy or any type of infusion. So another reason why they decide to put a Medi-Port is if the patient is going to get a vesicant medication. What's a vesicant medication? But what does vesicant mean?
Oh, like
It irritates the skin. Okay, if we as nurses insert an IV, we can give chemotherapy through an IV. But if something happens, the patient pulls by mistake the IV, and now it's not in the vein, we can literally burn the patient's skin. Okay, vesicant medication, especially most of the chemotherapists, chemotherapies, they are vesicant, so we don't want to cause that damage to our patients. I've treated multiple patients that got cancer back in the days in Mexico or even here. Vesicant was not a thing back in those days, so they come like with big burns on their skin, and guess what? We can't use those arms, we can't use those veins because there's a big scar tissue on top of it, and we can access them. So so that could be a reason why the doctor is asking for a Medi-Port, even though the medication, the treatment is going to be short term. The patient could have a PICC line, but they did go over the Medi-Port just because of the medication being a vesicant. So there's less risk of this becoming infiltrated versus having a peripheral line inserted. So one thing that you want to know, once you know of your patient, you know you're going to start a Medi-Port, you need to know the type of treatment that you're going to administer to the patient. It's always good to know the diagnosis, just in case you're giving chemotherapy and the patient has, let's say, left side breast cancer, and that's where the Medi-Port is. Maybe it's not going to be the best place, especially if the site is oozing or if it's red, swollen. You cannot access the Medi-Port if the skin is broken. So before you touch your patient, if it's the very first time that the patient will get the Medi-Port access, let's say the patient had it placed 3 days ago, there's no bruise, there's nothing there, you want to make sure that there's an x-ray of placement, okay? So put it on your notes, please. No accessing Medi-Port unless you have an x-ray showing that the tip of the catheter is in place. What happens? You go in, you say, oh, the surgeon place it, it's going to be fine, and then you give chemotherapy and it wasn't in place, and now you caused a burn on the patient's chest. So just make sure that you have that x-ray. Is the x-ray all that you need? No. If the Medi-Port, once you start it, and I'm going to go through those steps too, once you start it, if it doesn't give you blood back, you do not put anything in, okay? Back in the days when I started doing oncology, we used to say, oh no, but it goes through, but you cannot risk it, okay? Just don't risk it. Don't learn from our previous mistakes. Just don't use it. It's better if you send the patient back to the hospital to get an ultrasound done or another x-ray, just to check for placement if that's the case. Don't ever push anything if you don't get blood back, and don't try to force fluids if there's a blockage, okay? If it's giving you resistance and you know that the clamp, everything is open and it's still giving you resistance, don't even attempt it, okay? Because this is just this. There's nothing else. This is screwed in. As you can see, like I'm just turning it. If I continue doing that, this is gonna come apart. And I'm giving you my bad examples, but they're examples anyways. Back in the days, if the patient would come and I would try to access it and it was hard, I would try to maneuver and turn it around so I could access it eventually. But one time it became dislodged. So the round thing, it was just floating on the patient's chest, and the catheter was in place, but this was not attached to it. So we didn't give anything, but when we flushed with normal saline, we noticed that it got swollen, so the fluid was outside of where it's supposed to be. So don't do that, okay? Any resistance, no flush back, send it to have an x-ray before you actually access it. What are you gonna do about the medication that we're gonna give? You ask the doctor whether you can start a peripheral, if it's safe for the patient, or reschedule the treatment for another day, okay? So we already know that. We know the purpose of giving of accessing the Medi-Port. We know the diagnosis of the patient. We have an x-ray that validates that the Medi-Port is placed on correctly. And now you wanna ask for any allergies. Okay, we do use normal saline usually. The difference between this, another difference between this and the Medi-Port is that we do use heparin because the patient doesn't get chemotherapy every single day. We are not monitoring the patient every single day, and sometimes it's used only every 6 weeks when the patient comes to get maintenance of the Medi-Port. So you don't want to clot there, because if it gets clotted, it has to come out, okay? doctors here in the Valley, they usually like to keep the Medi-Ports after the patient completed chemotherapy for another year. Just in case, because with cancer, we never know if they're completely in remission or if the patient's gonna need another treatment. So something to take note, if you do clinicals at the cancer center in El Centro, is that if the patient rings the bell and they finish their treatment, that the patient has an appointment for come back for Medi-Port maintenance at least every 6 weeks, okay? We tend to do it every 4, just so we have 2 more weeks, just in case the patient can't come back. We still have 2 more weeks to wiggle their appointment around. But if it passed the 6 weeks, you don't even wanna try it, because definitely there's gonna be a clot in there, and you can push it in, and what happens? It goes into the brain, or it goes to the lungs, and you don't want those, okay? Yeah, or the heart. So you don't want that to happen. So once you flush it, the heparin, you want to follow the policies and procedures of the hospital, the clinic where you're working or practicing. Usually by the ONS, the Oncology Nursing Society, and the oncology organizations, is usually 300 units of heparin, which is roughly 1 ml per every 100 units, so roughly 3 ml. That's what this chamber can hold. So usually the heparin will stay here and it doesn't go through the patient's body, okay? So you know that when you access and you pull for blood, you're gonna take out like gooish, brownish blood. It's not gonna be red, it's not gonna be bright red for sure. It's gonna be diluted with that heparin, okay? You wanna take that clot out, because if you don't take it out, you just, oh yeah, it's red, I'm just gonna push it, just like we do with the IV. We see the blood flashback, and we start pushing our fluids. You're pushing that big clot, 3 ml clot, into the patient's system, okay? So you wanna push that out, and I'm gonna show you that technique right now, and then connect a clean syringe to start flushing, okay? So we already identify our patient, we read the chart, we know what our patient is going to receive, and we ask for allergies as well. We know the type of medications that the patient's gonna get, how often the patient's gonna get the treatment. Let's say it's the very first time that we're going to access, we need the x-ray before, and the patient's not gonna know anything about it, okay? So the way that you approach your patient has a lot to do, okay? If a patient has Medi-Port and you are working in the ER, so that Medi-Port wasn't for the ER, right? Can you use the Medi-Port? Yes, you can, okay? Another reason why the doctors order Medi-Port is because they have hard veins, okay? After so many chemotherapies, chemotherapy still tends to burn the veins from the inside, and they become very hard, and you see them, you feel them, and you're like, this one looks good. You cannot trespass because they become very hard with chemotherapy. So that's another indication for Medi-Port. If that's the case, if the patient doesn't have any veins and you cannot access any peripheral IVs, go for the Medi-Port, okay? Yes, you can use it. But your approach to the Medi-Port, it has a lot to do whether the patient's gonna allow you to touch it or not, okay? Yes, I confess, as an oncology nurse, we do scare our patients and we say, don't let anyone touch your Medi-Port. Because if they screw your Medi-Port, guess what? You're not gonna be able to get your chemo. And for cancer patients, chemotherapy is their lifeline, okay? So they're gonna be like, oh no, just Alicia can't touch my Medi-Port. And they learn the name of their nurse and they're like, nope, call Alicia, nope, you're not touching the Medi-Port. But if they don't have any other resources, you don't have any other resources, you have to go for it, okay? So with your personality, you have to convince the patient that, yes, you know what to do. Your knees might be shaking, you might not remember anything, but the patient doesn't need to know that, okay? So the approach that you have with your patient is very important. Show yourself confident, just look at the videos again, call Mrs. Alicia and I'll let you know, call your charge nurse or call the infusion nurse. You know, they do that every day, all day long, okay? That's most of the things that we do in the cancer center, more than IVs. So So yeah, show your patient that you know how to do it, and just tell them, look, I've done this a lot of times, you know. And who's your nurse? Alicia. Oh, I know her from. I was born with her. Like whatever you want to say. That has a lot to do with whether the patient will allow you to do it. If you go in and you say, I've never done this, and you know, and they see you sweating, you know, and shaking, forget it. Like you're not gonna be successful there. Okay, so if you checked all your checks, you know that you're gonna start your patient. The first thing that you want to do, let me fix this. Okay, so surgically wise, they just open a 5 centimeter site on the patient's chest. The physician decides whether, I don't know if it's an ini, mimo, or piedra, papel, tijera, but they decide where to put the Medi-Port. Usually if it's breast cancer and it's on one side, you put it on the opposite side, but sometimes it doesn't really matter. Patient has disease everywhere and they just place it. So they open a 5 centimeter incision. They just drop this in, literally, using sterile technique, and they drag this to the superior vena cava, and it goes directly to the heart. So this is not attached with anything. So this can move, okay? Once it's in place, we do instruct the patient to take care of it at the beginning because it feels uncomfortable. I'm pretty sure I've never had one in place. Only in my dreams. I remember one time I was so curious. I was like, does it hurt? Does it hurt? And one time I felt it in my dream. I was like, oh, it does hurt. I don't know why. It's just weird. Anyways, so you cannot see it from the outside. If a patient has big breasts or they're big, complexity, overweight or obese, you will not be able to see it. Okay, you will have to actually feel for it. If the patient is very thin, if it's very visible, if it's up here, then it has no, like, you can see it from the front, you can see it from the side, it's just a little bulky. Then the doctor closes the incision and they're good to go. There's nothing to actually care for after that. Recommendations that we do give to our patient is that at the beginning, try to sleep facing up. And if you need to turn, put a pillow on top and then turn. So that way the Medi-Port doesn't turn on its own with the movement. But then they get used to it and then they can do whatever they want. So now we have the patient with us. If the patient just had the Medi-Port placed, then we want to make sure that the site is not bruised. Okay, that there's no swelling, that it's not red, that it's not oozing, because if that's the case, we cannot touch it, okay? Because we can confuse if we create an infection. Hopefully, I know that none of these students are going to do that. But if there's an infection, we're not going to know if it was prior to or during the insertion of the Huber needle. We assess the skin. We introduce ourselves to our patient. Hi, my name is Alicia. I'm a registered nurse here, and I have an order to start your Medi-Port. This is a Medi-Port. The needle is Huber needle, okay? So we don't say, oh, I'm gonna place your Medi-Port because the patient already has a Medi-Port in place. So we tell the patient that we are going to insert a Huber needle. Now, I just have one. I'm going to open it, but then we're gonna pretend that it's still sterile, okay? So you cannot access the Medi-Port with just any needle, okay? And the reason why is because a regular blunt needle will dislodge the plastic from the Medi-Port, and you don't want plastic in the bloodstream, okay? Because again, it goes to the brain, it goes to the heart, it goes to the lungs, and we don't want plastic just floating around. So we need a Huber needle. The unique feature about a Huber needle is that the tip is not straight, is bented. Can you see it? Like the YouTubers are. I know. Can you see the tip? So if you see it like that, it's not that it's broken, and don't try to change it and open another because they're all going to be the same, okay? Meaning the needle. The little, it has a little hole in the bottom, and this will open the plastic it goes all the way in. You don't have to go like this, you just go straight. And you feel the back of the Medi-Port, the metal part. Once you touch that, you know you're in place and you can continue with your technique. Now, this part does change, okay? This is a butterfly type Huber needle, just like the butterflies when you do phlebotomy, if you do phlebotomy. You just hold it from the two little wings. This doesn't have the bio patch attached. The ones that El Centro uses and PMH, we used to use them too, they're called Gripper Plus. So they don't have the butterfly, they have an actual gripper on the side, and that has the bio patch. So we don't have to worry about putting another bio patch because that already has it on. They're very fancy, they're very easy to use, but they're very expensive. So that's why we've got these, okay? Excuse me?
Yeah.
Yeah, I know, it's like being in hospital, right? So, and it has one catheter only, and this, you can attach whatever you guys want. You can attach a syringe to it, you can attach an IV tubing, you can attach a Y set, whatever you want. This is very standard, okay? So this is your, oh, and it also has this clamp right here. This is very tricky because usually we clamp it and then we forget and we're giving the medication. It has happened to another Alicia, not this Alicia. And the machine is beeping and beeping and beeping, and I'm like, oh, I'm gonna have to remove the Huber needle because it's not working, and asking the patient, turn around, cough, lift your arm, and do all those, exercises to try to get it to work, and it's not working, and as soon as I remove this, I know that, this is the one clamp. So, don't clamp it, okay? What we usually do, and I'm doing it right now that it's up here because once it's there, it's gonna be harder for you guys to see it. I just thread it to the side, and then I clamp it. That way this can move freely, and it's not clamping my fluids, okay? If I need to clamp it, I just have to remember to open it, put it through, and clamp it, and that way it's not gonna move, okay? So we don't like those little things. It comes with this plastic. You don't need it afterwards, but it comes to protect the needle, okay? So I'm gonna try to find my glasses, because I don't wear glasses, right? So this is your Huber needle, okay? Like I said, it comes in different flavors, but whatever your institution has, that's what you're gonna get. Talking about institutions, we have a dressing change kit that has most of the things that you guys are going to use, okay? I don't know about ECRMC, but I know PMH, they did their own kit, okay? Very fancy, it has step 1, and what you use in step 1 is step 2, is step 3, and it's like, super cool. The bad thing is that if you drop something or you need another alcohol, guess what? It only has one, so you have to open another one. So it was not, for my point of view, it wasn't cost effective, but that's what you guys have on the floor. In the cancer centers, in the infusion centers, we have everything separate because we already know what we're gonna need. We don't need the step 1, 2, and 3, and we can just grab like bunch of salines in one pocket and your heparins, not the heparins because those are patient charged, but we have also all the supplies flying solo. So we just get whatever we need. Once you have your patient, you assess everything else, you checked everything. You want to feel for the Medi-Port and make sure that you know where it's at because you want to be sterile with your Huber needle and not find the Medi-Port and start looking for it. It's usually on the chest place, but I've seen Medi-Ports on the arm. I've seen Medi-Ports like very close to the nipple of a big-breasted patient. Why they would do that, I have no idea because it's very uncomfortable. It's uncomfortable because you have to access it. So imagine that, poor lady, we had to uncover her and look for the Medi-Port like close to the nipple, and she had big breasts, but that's what the doctor decided, so that's up to them. But it's usually on the top, it should be on the top, and so you go, you ask your patient, you introduce yourself, you wash your hands, you knock on the door, you do all those first semester skills, and what you wanna do is you wanna ask your patient, can I look at your Medi-Port? Why would you wanna, once you found it, why do you wanna feel for it, besides knowing where it's at? Okay.
The positioning of your hands to make sure you know where you're gonna be as soon as you're sterile.
Okay.
Make sure it's not backwards.
Or, yeah.
It's facing right, like the right way.
You wouldn't know that because it has skin on the top, so it's not gonna, you're not gonna feel it. Because the Huber needle comes in different sizes. Longer, I know. So we have, the usual one is 3/4 of an inch long. But you have 1 inch, you have 1.5 inches, and you have 2 inches, okay? The usual one is 3/4. It's for this type of Medi-Port. Very superficial, you can feel it. You feel the skin and you can feel the roundness of the Medi-Port. That is a 3/4, okay? It's gonna go smooth in. It's not gonna have anything hanging outside. For those patients that have the Medi-Port, they're big patients, overweight, or the Medi-Port is in a place where there's a lot of fat tissue on the top, then maybe you wanna use a 1 inch or 1.5 inches. But those are like huge needles that if you don't have anything else and you have a very superficial Medi-Port, but you only have a 1 inch Huber needle, it's gonna be sticking out, okay? And it looks scary because the needle is out there and the patient can see it like, oh, it's coming out, but it's not. It's just that it's too big for the patient. So you wanna kind of like have an idea of, this is a 3/4 or it's a 1 inch or whatever it is. If the patient is not, it's a return patient, they have had treatments there before, or at least a Medi-Port access in the clinic, you can go back to the chart and see what Huber needle size the previous nurse used. And that way you don't have to, you know, it's not a big brainer, bless you. So once you felt for it, you tell your patient, okay, I'm gonna get ready and I'm gonna go get my supplies. You go, you wash your hands. We are going to need, in this case, my facility has, IBC facility has the kit. So you want the kit, you want at least 2 normal saline 10 ml syringes, okay? At least, I used to use more, but that's all I got today. So I'm gonna work with whatever I have. You need your Huber needle of the size. You need your ultrasite. You just need 1 because the catheter only has one port. And if it's not a Gripper Plus, you need your bio patch. If the kit doesn't have alcohol and the betadine, you wanna have those as well. And you're gonna need tape, okay? Just plastic tape. Now, if the patient is allergic, then you don't wanna use the tape on your patient. If the patient, if you know that the patient is coming for a treatment and you're gonna use a Medi-Port, in the cancer centers, usually a nurse talks to the patient, okay? About nursing stuff. The doctor explains the treatment and the outcomes and everything else, side effects of the medications, duration of the treatment, and you as nurse, you wanna tell the patient, I'm gonna be accessing your port, this is the prep that you need to have beforehand. Make sure that you tell your patients, especially female patients, wear a shirt that is open, because I'm gonna have to access. If they have a turtleneck or they have a closed shirt, you're gonna have to uncover everything or ask the patient to take it off, okay? If you haven't been in one of those infusion centers, the patients are not in rooms, like private rooms, okay? It's just an open space, and it has little dividers or curtains. In Raleigh, we have curtains up and down. I think here in El Centro, they have a little wall, half wall. And the purpose for that is because the nurses have to be constantly monitoring the patients. We cannot leave the patient unattended because chemotherapy can cause an allergic reaction in terms of seconds. So we need to, there's always someone checking on those patients. So you don't want to uncover all the patient's breasts in front of everybody that is just passing by because you didn't tell the patient to wear an open shirt. So button shirts, that way you can open one side, or something that you can just uncover what you need to uncover and not the whole chest. I used to tell them, I just don't have too much time to tell you guys my stories, although I told you like 5 already. But I used to have this patient that she would come, and every time she would come, she came for a few months, and she would just say, just cortala, just cut it out. And I was like, oh, but this one is pretty. No, just cut it out, it's fine, and just cut it out. And I knew that she would either forget, she didn't have any, or I don't know, but she would always want me to cut until one day her husband came, and she was like, oh, you're Alicia, and I was like, yeah. And my the favorite nurse? And she was like, no, you're the one that always cuts her shirt. So every time we leave here, I have to take her to the mall to buy another shirt. So the patient wanted a new shirt every time she would get treatment, and she would tell the husband, oh, Alicia ripped it, and she cut my shirt. So I was to be blamed for that. So just, if you know your patient, you know they're gonna get treatment, make sure that you prepare your patient and you tell them that, okay? So you have your patient has been prepared. If the patient is coming back, they might be prescribed EMLA cream, okay? That's an anesthetic, local anesthetic medication that we give to the patients. So if the patient is coming back a day before or treatment before, they will get that little tube of EMLA cream, and they will take it home. EMLA, E-M-L-A. Welcome. And they're gonna take it home, and you're gonna tell the patient, put a quarter size on the site of the Medi-Port, a quarter size of that EMLA cream. You're gonna give them a little Tegaderm, and you're gonna cover it, okay? When they arrive, you're gonna ask them, oh, you have the EMLA cream, when did you place it? Because EMLA cream has to be on site for at least 30 minutes, okay? So write it down, 30 minutes for EMLA cream. Then you're gonna remove the Tegaderm. You're gonna remove the excess of the cream, and then you're gonna prep the area just like you would, okay? But now that area, if it's been 30 minutes, it's already gonna be numb, okay? Don't get scared if it's been there for more than 30 minutes. It's the longer it stays on the skin, the better it works, but at least 30 minutes, and that's a full effect right there. After 30 minutes, the skin becomes white, pale, okay? Don't think that if there's something wrong or the patient is allergic, it's just the nature of the EMLA cream. It turns the skin white, okay? Nothing happens, it goes back to its normal color after a few minutes. So if that's the case, that's what you would do. Some patients don't like the EMLA cream, or they forget, so they're like, just whatever, they don't wanna wait the 30 minutes. Once they get there, then you have to wait another 30 minutes to start the medication, and they just decide not to have it. But it's better if you ask your patients for that, and you need an order from the doctor for the EMLA cream. There's another anesthetic also that is the pain ease spray. It's just a regular spray of alcohol, but the pressure makes it very cold. And you have that one on site. That one you don't give to the patient. You have to, once you use that one, you have to start the Medi-Port or puncture the skin within 5 minutes versus the EMLA cream. The EMLA cream, the longer you leave it, the better it is. The spray, if you wait more than 5 minutes, you're gonna have to spray it again because the effect is already gone. So, tricky part about it is that it's a multi-dose vial, multi-dose can of the spray. So it's not sterile, so you can use it with other patients as well. And since it's not sterile and you already cleaned the site, everything is ready, you spray it, you have 5 minutes to do everything, okay? So if you're not fully trained on how to start a Medi-Port and you know you're gonna take more than 5 minutes, don't use the spray, because by the time that you're gonna start it, the effect of the spray is gonna be gone, okay? So that's a good practice for you. Try to do it within 5 minutes, that way you can offer the spray to the patient. There's some patients that say, don't give me the spray because it hurts more than because it really numbs the skin. It hurts more than the actual needle, so they prefer no spray at all. So whatever the patient wants, but you have those two options. So let's say this patient came without the EMLA cream, they don't want the EMLA cream and they don't want the spray, I'm just gonna go ahead and start it as is, okay? So I am going to try my best. I am lefty, and the Medi-Port is on that side. So I'm gonna try my best to allow you to see what I'm doing, okay? So I already washed my hands, I checked my orders, I did all my checks, I chat with my patient. He allowed me to start his Medi-Port. I have all my supplies too. I'm at the bedside, same as Ms. Ramirez told you. Make sure that before we used to use betadine, and the betadine was orange, so we would stain the patient's clothing. So you want to do something like this and just expose the Medi-Port. I'm not going to do it with him because he doesn't have a shirt, so it's just going to fall down. So I'm going to use my kit, open my kit. Usually you don't have these in the hospital. You have either the supplies alone or those fancy kits that they made for for the patients, for the nurses. So you have your patient close to you, you're already located in the Medi-Port. I know it's a 3/4. You want to use a face mask, and you want your patient to wear one as well, okay? So I put mine on, I already gave him one.
Do you need a hold of mannequin?
I'll let you know. You're gonna have sterile gloves inside of the kit. You might wanna have an extra pair of sterile gloves as well. So I'm gonna take my gloves out. And I usually use my gloves as my sterile field. And I wanna put in my puber needle. Let's pretend that it was a new packet.
I have a new one, no, that's not 3/4.
It's okay,
Yeah.
okay. They're not gonna tell on me, I think. Now, this is tricky because usually this is how you're gonna see them in the hospital. The kids don't have a sterile, normal setting. If they do, good for them, but in the years, have you seen the sterile ones? No, huh?
Not for that.
So, since these are not sterile, you cannot throw them in the sterile, field, okay? But you can take them out of the packet. How much, of the space of a sterile field do you have to maneuver? 1 inch, okay? So you wanna put it within your 1 inch. Just to have it available because you will need it when you're still, sterile. So you just wanna put the tip on your sterile field. You wanna do both of them, just in case you need the other one, you already have it set there, okay?
No, go ahead.
You will need the head wrap, but until you remove the puber needle, not to start to make the medicine. I'm gonna have a hole there. I'm gonna throw in my bio patch because that needle doesn't have a bio patch. So I sanitize my hands. You can do all that with clean gloves as well. Once you put on your sterile gloves, there is no way around, okay? You cannot touch anything. For some time, we heard from the ONS that, Oncology Nurse Society, that, it wasn't, like, policy anymore to use, sterile technique. But then they went back to just sterile technique, so you do wanna do it, using sterile technique. They were like, oh, it's because it's just a little hole and nothing's gonna happen. It's still a central line. You don't wanna risk it, okay? So always go to your policies. These gloves are ugly. Okay, so I have the betadine here, which I'm gonna open and leave it ready. And I have alcohol. Okay, so now I am going to tell my patient it's gonna feel a little cold. You're gonna start center out with strong strokes, okay? You have no idea how many times we discharge patients, they came 3 weeks after, still with the Band-Aid from the last treatment. Okay, so imagine under that bandage how many creatures you can find. So make sure that you really clean, okay? Because everything that is there is gonna go in along with the Huber needle. So you start from the center of the port with strong strokes, and you're gonna clean outward at least 2 inches around the Medi-Port, okay? Give yourself some space. And if you need more alcohols, that's why we didn't have kids in the cancer centers. Because if we needed more, we use more, okay? Don't be stingy with them. If you put spray, the spray should have been there already, and these are my 5 minutes of time, okay? I'm not gonna put this one because it's gonna stay in the mannequins, right? Mr. Ramirez?
Yes, don't.
Okay, so we clean with your 3 betadines, if I remember. So now it has the betadine there, and then you have the betadine there, and you let it sit for a little bit while it dries. In the meantime, you don't do this, but I wanna stay in the mannequin. You grab your Huber needle, okay? You remove the little plastic. You make sure that it is a Huber needle, that the tip is bended. Okay, you inspect it. You get your bio patch. What goes to the patient? The blue or the white? So you put it in. These are a little tricky, okay? Because these may fall. But like I said, if you're gonna be doing nursing here in the Valley, they have the fancy ones. You don't have to worry about the bio patch, because then these you have to hold them. So make sure that the opening is on the bottom and not on the top, so that way when you hold it, you're not pushing it out, okay? So you hold it, you prepare your needle, but then you need to flush as well. This needs to be primed, okay? The line needs to be primed, because once you put it in there, the next step will be to flush it or to pull the clot, and it has air. All this has air. So you have sterile 4x4s. You're gonna use one to grab your flush. You don't want to touch anything that it's not sterile with your sterile gloves, okay? So you connect your flush. You should never use a syringe smaller than 10 mLs, okay? On a Huber needle. So write it down. No smaller syringe than 10 mLs. That is because, like I told you before, the Medi-Port is connected to the catheter, is just screwed on. So the smaller the syringe, the bigger the pressure, okay? So you can dislodge the Medi-Port from the catheter if you use a smaller syringe. Doesn't matter if you're only gonna administer 1 ml directly into the Huber needle. You load your 10 ml syringe with 1 ml of fluid or whatever you're using, okay? So you wanna do that. This hand's still sterile. My other hand's still sterile, but the syringe is not sterile. So what I wanna do, make sure that this is unclamped. You wanna prime it, okay? So you wanna flush it. So you have your bio patch. You have your needle. I'm not gonna touch that. This hand is going to touch my patient. I'm not gonna be able to use it for sterile technique anymore, okay? Can you hold on my patient? So with this hand, I'm gonna locate my Medi-Port. I'm gonna feel for it. It's right there, 3-point anchor. With my needle, I'm gonna go straight in the center of it, okay? So sorry if I'm giving you guys my back. And once I'm there, I just push in. Okay? No fear. Just push in. Okay? As hard as you can. you're gonna feel the back of the Medi-Port, okay? You're gonna hit the back of the Medi-Port. So once it's there, guess what? Sterility is no longer an issue, okay? The needle's in, the biopatch is around, there's nothing else open. You can feel free to touch whatever you need to touch and do whatever you need to do, okay? So you can let it go if you want. So this was primed already. It's open. Before I give anything, what do I have to do?
Pull back.
I have to pull back, right? So I'm gonna pull back. And I'm gonna bring my clot to my syringe. Once I have the clot in the syringe, the catheter has blood in it. You're gonna clamp it, and you're gonna change your syringe, okay? I'm not gonna do a blood draw. You can draw blood from a Huber needle, okay? Help your lab technicians, your phlebotomist. Sometimes they have an order for a blood draw. The patient is in the hospital. You're starting a Medi-Port, and they cannot access any veins. If you see them, you can say, oh, let me help you out, and if I'm starting the Huber needle, I can draw the blood from there, okay? So make sure it doesn't have any saline. You pull before you get your specimen. You can disconnect it from here and connect your empty syringe to draw the blood, and then you connect your saline, okay? So let's say this was my clot. I discard it. I grab a new 10 ml syringe, get rid of the air, because you don't want air inside. You connect it with your syringe like this. Why do you want your syringe like this?
Gravity.
Gravity, what does gravity do? No?
Not that much pressure.
It moves the air bubble up.
Yes. By doing this, if there's any air on the line or on the syringe, it's gonna go to the top. See my air right there? So there's less risk of you pushing the air versus doing this. If I do this, my air bubble will go to the tip, and that's the first thing that's gonna go into the patient, okay? So you always wanna do this technique. Make sure that you open your clamp, and you're going to pulsating, give 1 ml at a time, okay? Give 1. Before you finish, you clamp to create that pressure, that negative pressure, okay? You can, I'll leave it like that for a little bit, and I want my step, my ultrasite. I want to prime my ultrasite. So I have another syringe. See, I would have used 3 syringes, one for the clot, one to flush, and the one for the ultrasite. So you connect it, you get rid of the back part, and you prime it. Once it's primed, this is locked. I get rid of this syringe that is empty now. It's already primed it, and I connect the new one. You don't have to give the 10 mLs. You open, 1, 2, 3, 4, whatever you wanna do, and then you clamp it. You put a little green tap, or just like Ms. Ramirez said, and it's ready to go, okay? Now I want to cover it so it doesn't become, it doesn't come out. So you use your Tegaderm if the patient is not allergic to the Tegaderm. You wanna cover the whole needle. In this case, you wanna lower the wings of the butterfly, and you put it over. You put the date, your initials, you label it, you put the size of the needle, of the Huber needle. Usually what we do, since we're gonna be connecting a lot of things to this, we tape it to the top, okay? But follow your clinic's policies. Usually that's what we do, because we don't want the patient, they usually go to the restroom, they stand up, they start walking, or they're getting their treatments, and if they pull on this too hard, they're gonna disconnect the syringe, the needle, sorry. So you just leave this, and they start connecting everything through that little port, okay? To remove it, let's say the patient already finished with the, take this off. Let's say the patient already, you get rid of your stuff, you wash your hands, you go and you document, patient tolerated, what you flush it with, the size of your needle, the time that you started it, and what you connected, because usually we already have a primary bag of normal saline, 250, whatever the treatment the patient's gonna get, and you connect it right there and then, just to keep it open, so it doesn't clog. You get rid of your trash, and once the patient is ready to go, let's say the patient will come back in a week, 2 weeks, 3 weeks, whenever the patient is coming back, you're gonna get rid of everything, okay? So, first, you want to flush it. You're gonna flush it with 10 mLs of normal saline. You're gonna then flush it with the heparin, according to your hospital's policy. Usually it's 300 units, 3 mLs of heparin. They come in pre-filled syringes, but they're labeled yellow color. And you flush it, you clamp this, and you start getting rid of your tapes. Be gracious with the tapes, because your patients that are on chemotherapy, the skin becomes very dry, very sensitive, and very thin. And it has happened that we just remove the tape. I don't wanna see it yank it, but yes, we do. And the skin of the patient comes along with the tape, okay? So you don't wanna do that. It doesn't matter if you spend more time removing the tape than what you did putting the needle on. You wanna be very gracious with the alcohols, okay? He's not gonna complain because he doesn't have a mouth, but, so I'm just gonna try to do it fast because I'm gonna stop right now. This is exactly what you don't do, okay? Okay, so once the tape is out, you hold the needle by the wings. You, with 2 fingers, you wanna hold on to the Medi-Port, okay? Because if you just pull the syringe, it's gonna bring the Medi-Port with it, and it's gonna hurt a lot. So you wanna hold on to the Medi-Port, ask the patient to take a deep breath, and you count 1, 2, 3, and you just pull it out, okay? You throw this one away. These have a security site that you just pull it out. If you can see them with the tape, you can hold on from the wings. Let's say it was there. You just hold on from the wings and you pull this, and there's no risk for you on poking yourself. Like I said, they don't use this type of needles in the cancer center. What they do is that they hold it from the Gripper Plus, and it has, the syringe has a little device on the back, and you pull it, and that's what covers the needle, okay? So once it's like that, it might not bleed. Sometimes I see, because the skin, a little drop, so you wanna put a 4x4, let's say that this one's clean. You fold it with a little piece of tape, or a Band-Aid will also work. You just tell the patient to leave it on for 20 minutes, and once the 20 minutes are over, they can remove it, and there's nothing that they need to do about it anymore, okay? Nothing's gonna go in, nothing's gonna come out, and they're free to go home. If the patient is not on chemotherapy and they just come for maintenance of the Medi-Port, you're gonna do everything, but once you flush, you also put the heparin in, and you remove the needle, okay? You avoid the extra step of flushing too many times, of putting the ultrasite. They're not gonna need the ultrasite because they're gonna go home right away. So you just start it, do the whole skill. You start it, you flush it, and then you flush with heparin, and then you remove the needle, and that's it. You don't have to put the Tegaderm, nothing.
You would just leave that.
You would just use this, So if the patient comes for maintenance, it's very quick, in and out, and they leave, okay?
And you still pull back for the clot when they're doing maintenance, right?
Yes, always pull your clot before anything. Before flushing, pull the clot. If it's not giving you the clot, what are you gonna do?
Now you-
Check. No, the,
Check for placement. Yeah, send them to have ask for an order for an X-ray and make sure that the Medi-Port is placed, correctly. What the nurses are trained to do as well, if it's clot, they can use the cat flow, but you need a training for that, okay? We used to get a training on how to use the cat flow. That's just a powder you mix, compound it with a fluid, you put it on you load your syringe, you give it to the patient and you leave it there for a few minutes. And then you go in back after a few minutes and you check to see if there's blood return. If there's none, you give more and you wait a little longer, and then it should give you, if it's just that it was very clotted, it will give you the clot back. If that didn't help, then you send them to, for the X-ray, okay? But you need an order for the cat flow, and you need a training for the cat flow as well.
Can you go over the 3 syringes? The first one is to remove the clot, the second one is the flush, and the third one is.
It's, so you can use 3 syringes, one if you're gonna draw blood.
Oh, okay.
So you're gonna need an empty syringe. After the clot, you do your empty syringe to pull out for blood. If you're not gonna give any blood, you just need to flush it, and that's it.
So it'd be 2.
Mhm. And that flush will have your ultrasite attached to it, okay? You don't need a third syringe, okay?
I have a question, can you show real quick, how did you hold it to put the needle in the?
It's three point, so you use these 3 fingers. Remember it's round, so you just have to hold it from the edges of it.
Like this?
Yes.
Oh.
Mhm. And
They were covering?
use your badge, unless you have a fancy one. Oh, hers have ears. Like a badge. Yeah, you can use your badge as a reference.